The first video was the guy with, fire behind him, apparatus behind him, holding a baby.
The ultimate.
Yeah.
Midnight, Christmas Eve. He calls us back.
You are listening to EMS with your hosts, Erik Axene and Matt Ball.
Well, we had an interesting conversation this morning. I think this is going to be a cool topic.
Yeah, it's a topic that's, it's always a hot topic when you talk about EMS and the fire service.
Yeah.
That is always a fun topic to discuss.
But I think that most people don't realize some of the things you're about to say. I mean, that most people's perception of the fire service or a fire department, what they do, is not really a reflection of reality.
Yeah, I think both from the civilian standpoint, like I get asked all the time, are you a firefighter? Are you a paramedic? Like, what are you? And so explaining that to the general population, but
what do you say? What, by the way?
Oh, I mean, we're both. I'm both, which is true.
Yeah,
like we're dual certified, right? I'm a firefighter and a paramedic in my department, right? I ride. The way that we usually rotate it is you do 2 shifts on the ambulance and then 1 shift on the engine. Obviously, that changes up a little bit. But we fight fire off the ambulance. Most of the departments in this area, if you're on an ambulance, I have all my gear on the ambulance. So if we get a call of structure fire, we have 2 ambulances in my city. 2 ambulances automatically are dispatched to that call. But before we start, I think we need to remind everybody to like, share, and subscribe to our podcast, follow our page, and...
Like is the thumbs up thing?
Yep, like,
share.
Thumbs up, subscribe to the YouTube page. That helps us out. And then comment, like if you have questions, you can put comments on there. But also now we're offering something new. We can actually issue CE credit for this podcast. But there's a caveat to that. That has to go through the website.
That's right. AxeneCE.com.
That's right.
And you sign in. You can get credit for these podcasts.
That's right. A lot of people have asked us, hey, is there any way I can get CE credit? I love your podcast. Can I get credit for it? Yeah. I mean, our lectures are pretty similar to our podcast, the format.
Yeah. We're just a little more...
Yeah, a little bit more formal because it has to be, right? The rules and regulations where the podcast can be a little bit more casual.
Correct.
But if you need this to get the actual credit, you have to get the certificate and all those kind of things, the objectives, the questions, those are all standard. You have to do that.
Yep.
And so that's why you have to do it through our website. So go to AxeneCE.com and you can get actual credit there. We're bumping knees together. But yeah, it's a very interesting, fire EMS in the fire service.
Yeah.
It's, a lot of firefighters, I think I was recently watched a video on social media where the National Registry was talking about how fire department advertising, when they're doing recruitment, it's almost a bit of a bait and switch because, you see these posters and join that, whatever fire department, and it's always got a dramatic fire photo of somebody on an aerial ladder or somebody going through a door filled with fire or whatever. And so it's this mindset of you think, oh, I'm going to get into the fire service and I'm going to be fighting fire. That's what I'm going to be doing. You watch TV shows or movies and you think, I'm going to be dangling off buildings and, doing all this kind of stuff. And that's not totally reality.
It's funny you mentioned that. I was just at a conference at Myrtle Beach last week, the Metro Fire Chief.
Yep.
And there was a promotional video. I can't remember which speaker did it, but there was a promotional video related to fire. And the first video was the guy with, fire behind him, apparatus behind him, holding a baby.
The ultimate.
Like it really is the ultimate, right?
That's the ultimate.
But that was kind of what you're saying is that's a rare occurrence.
You know how many babies I've pulled out of buildings in 20 years?
In 20 years, I'm going to...
Sorry, you were going to guess.
Yeah, no.
0.
No,
Never happened.
And in some areas, that may happen more frequently, but
For
still,
sure.
even he told me, I think in New York City, there was a guy with decades of experience. And
on Rescue 1.
Rescue 1.
Yes, these guys go to all the big stuff.
Yeah.
And he said that I think he was the captain there for 20 years, and he said he had 4 legit rescues. Which means
Any babies in
he
pajamas,
didn't specify if it was a baby or not, but I mean, obviously, if you work in a large urban department, especially maybe a lower income area, you certainly see more fire. If you work for Houston or LA or New York, Chicago, these big cities, and you work in rougher areas, you're 100% for sure seeing fire. But even in those departments, you're still running EMS calls.
And I think that there's something about a firefighter that and yourself included, I think, and there was a time in my life I was applying to become a firefighter. I wanted to put myself in the position to save somebody's life. So absolutely. I think there's that. But the reality is, if your expectations are every day you're fighting fire to go save people from a burning building, you're not reality. But certainly being available to do it. It's like an ER doc, right? I've been trained for a bunch of procedures that I rarely do. Right. And I'm excited for them. I train for them. But most of the time it's, what do you call it? Poo-poo pains?
Poo-poo pains and grandma.
You said lift assist, I think.
Lift assist and poo-poo pains.
It's like that in the ER, though. I mean, it's like sore throats and...
flu-like symptoms, like tummy hurts.
Fever in a kid or something. It's just, and again, and like we've talked about this before, 50% of people in the ER don't need to be there. Right. And so I think that in the EMS service too, it's like we're transporting people that don't need to be transported.
Constantly. Yeah. Yes. Yeah. And there's there's some misunderstanding around, what is EMS there for, a 911 EMS service. And the general citizen, I don't blame the average citizen, for calling 911 because what is an emergency to you might not be an emergency to me or vice versa, right? And so I certainly don't blame the general citizens. Now, when we're talking about some facilities...
True. I have to say something, though. If you're a 25-year-old man with a ladder, check the smoke detectors first. You didn't say it. I said it. I'm the ER doc. I'm the medical director that's gone on the calls.
Well, so story time. Well, I'll give you a little story time. I might have shared this story with you, but it was Christmas Eve. Okay. We were on shift. About 8 o'clock that night, I was on the engine that night. Actually, I think I was driving. And we got a call for a residential fire alarm, smoke detector.
Yeah.
Show up at the house. Okay, fine. And the guy's like, yeah, my smoke detector's chirping. We're like, okay, people don't know. We educate them, right? No big deal. So we go in, and this guy was a big, tall guy. He was probably 6'3", 6'4", big guy. Well, the smoke detector, literally, my captain was a big guy, too. He could literally just reach up. No ladder needed. Just reached up, grabbed it with his hand, took it down. We cleaned it out. We changed the battery, did all the things. And we put it back up. And my captain tells him, he says, hey, if this happens to go off again or starts chirping again, it's probably a bad detector. And so he shows him how to do it. He goes, just twist it, unplug it. You'll have to get a new, go to Home Depot, whatever, get a new detector.
Yeah.
Guy's like, okay, fine. Midnight. Christmas Eve. He calls us back. We're like, bro, you're a grown man. Like, again, if it's an elderly person, like, please don't get on a ladder. We don't want you falling. But, like, you're an able-bodied, 6'4", able-bodied 35-year-old guy. Like, come on, bro.
Who's already called.
We've already taught you this is not rocket science, right? Or the amount of people that don't know how to shut the water off to their house. That's a whole other issue. But these facilities, when it comes to EMS, burnout is a huge problem. And, guys get sick and tired. First off, if you go into the fire service, I think we need to start there. If you go into the fire service, in the modern day fire service in America, nationally, the majority of EMS calls are run by fire departments. Right? There's private ambulance companies all over the country, but the majority of EMS calls, 911 EMS calls, are going to be run by a fire department.
And last year I looked at the data. 70% of all 911 calls were EMS. There were only 2% that were fire suppression.
And that's nationally. So you have to think, within those numbers are those places we talked about. Houston, Dallas, L.A., Chicago, these big urban areas that are probably doing the bulk of the firefighting, right? Yeah. In my department, we had a structure fire yesterday. We certainly fight fires, but not to that level that everybody, not on Chicago fire. That's not reality. Right. And so people get into it thinking that's what they're going to be doing. And the reality is that the bulk of what you're going to be doing is EMS calls, right? Yep. And to quote my chief, EMS is what moves the needle in the modern day fire service. And the reality is, whether you choose to like it or not like it, it is a reality, is that most citizens nowadays are not concerned with, dying in a house fire in the middle of the night like they were 30 years ago. We've talked about this before. What they're more concerned with is that they're going to have some sort of a severe medical emergency. They're going to have a heart attack, or their loved one's going to go into cardiac arrest or something like that. And they want to know that whoever is responding, whether it's a private company or the fire department, They want to feel confident that the people that are showing up are competent providers that know what to do.
Correct.
Right. And so for all the people out there that are looking to get into the fire service, just know that, yes, firefighting, extrication, all that kind of stuff is a part of the job.
Yeah.
It is not what you're going to be doing on a daily basis, by far.
Yeah.
And so, training like we do is a huge part of that. You have to be ready to go on these emergencies. And I think a lot of times, too, from a leadership perspective, whether it's a medical director or officer, chief level perspective, EMS is changing, right? And we are now considered, really since 2020, we're considered part of the healthcare team, the overall healthcare team. Every paramedic hates it when they're called an ambulance driver. Well, then don't be an ambulance driver, right? Don't just give them a dose of diesel. Like, that's why they're calling you an ambulance driver, is because that's all you're doing. You're not starting IVs on patient that needs IVs. You're not administering oxygen to patient that needs oxygen, right? And so if you don't want to be called an ambulance driver, then treat your patients, right? Be part of the healthcare team. Yeah. But a lot of guys don't understand the why behind things. Like antibiotics and sepsis, which we've talked about. Yeah. I had one of our guys go, we're doing all this new stuff. Why are we doing all this stuff? Why don't I get this all the time? It doesn't matter what department I'm at. I get it all the time. Why can't we go back to just doing it like this? I just don't understand. Well, the reality is we're not doing that, because what we're doing now is shown to have dramatically improved patient outcomes, right?
That's right.
That's why we're doing what we do. We're not just doing things. The medical director isn't just saying, oh, we're going to throw antibiotics in a sepsis protocol just so I can say that we give antibiotics.
Yeah.
There's data behind that, right?
No, there's a lot to back up. It used to be, and it still is to a large extent, the only time a fire department would get reimbursed for their services would be when they transported to the ER.
Right.
And that's an archaic reimbursement system.
Right.
And that's changing.
Yep.
And it's there's more accountability now. People are starting to look at the data. We didn't always have data, but with our EPCR systems now, we're collecting data. We can see how long it took a patient to get an EKG, or if they got one, or how long it took to get the IV fluids on a septic patient. That's or right. did you identify sepsis?
Stroke activation, STEMI activation.
All of that.
Yes.
So there's more accountability now on the quality of care that we're delivering before the ambulance bay doors. Yep. And that's what you're talking about. And so there is data, just came out, I think just this last year, when we treat sepsis patients properly, we can decrease mortality rate. For every hour you delay treatment of sepsis, and that includes antibiotics, IV fluids, activating the sepsis or whatever, you decrease mortality rate. Every hour you delay, you increase mortality rate 7%.
Right.
And it was interesting when they separated out the data on sick ones, septic shock patients. We'll talk about this at some other podcast, but the sickest of all the septic shock patients, if we miss it and delay their treatment, mortality rate is going to be going up, even if you don't get antibiotics early.
Right.
So, and there's some other data out there that just came out just in the last few months. I think actually it was January of 25. It showed that there was no benefit for early antibiotics, which refuted a lot of the earlier studies that said there was a benefit.
Right.
And I would argue that there is a benefit. That study that said there wasn't a benefit was only representing about 4% of septic shock patients. Right. So you had a less sick patient population. So you're not going to see a lot of benefit, right? But when you get the sickest patients, I think there really is a benefit, and hours count. And the data shows it, 7% for every hour we delay treatment.
It's to go back to what you said kind of at the beginning was about like life-saving. Yeah. And I say this a lot of time, and honestly, this will probably piss off a lot of firemen, if I'm going to be honest, that are in the fire service. They're going to get mad.
I think it's fun to make people mad. Get the tip of the spear,
Well,
it's like challenge the status quo.
You need to challenge, right? And so my challenge to the mindset.
Respectfully.
Yeah, absolutely. So I am not negating being a capable firefighter in any way, shape, or form.
I know.
I am not.
I know
saying,
your heart. I know you.
Yeah, this is exactly So here's my analogy. Okay, when I get a firefighter, a paramedic, whether I'm teaching a class or in my own department, and they ask me, well, why are we doing this and why are we doing that? I don't just give them a dose of diesel. Just take them to the hospital. Let the doctors do that kind of stuff, right? My response to that is, if you have a dying patient, whether it doesn't matter what they're dying from, trauma, STEMI, whatever. You have a dying patient in the back of your ambulance. And your choice is to just say, whether it's out of fear because it's a complicated skill, a crike or something like that you've never done before, you've been trained on how to do it, but you're scared to cut somebody's throat open or whatever the case may be. You don't want to take their airway. You don't want to administer the antibiotics, whatever it is. And you choose instead to, let's just go to the hospital. Let's just go, right? To me, that is no different than we pull up on a structure fire. I pull a line to the front door, and we open the door. You know, we look in, and fire is just rolling in that house, right? Or it's full of smoke. It looks scary and dangerous in there. And we're being told there's somebody in that building, right? What if I were to put the hose down, put my tools down, and say, I'm not going in there. Let the next guy do it. Let the next engine or the next truck, let them do that.
Right.
I would be crucified by the entire fire service if I did that, as I should be, right? Like
Can you be fired for cowardice?
I would think so. Conduct unbecoming, for sure. Okay. I would think so. Like, you're failing to do your job, right?
That's an oath you took.
Absolutely. You risk a lot to save a lot. You risk a little to save a little, right? And, you know, I mean, again, we've talked about this before where, you know, some firefighters aren't going to, whatever. You know, hopefully everybody understands that is part of the gig, right? If you're a cop and there's a school shooting, you're not backing out. And we've seen examples of cops that have done that or departments that have done that, and it doesn't end well for them, right? No. And so I would hope that most people understand nobody wants to do that. Nobody wants to die in the line of duty, right?
No.
But you should know that is a possibility if you go into this line of work. But back to the point, is that if I back out it, to me, what is the difference? Is if I'm saying I'm not going to risk my life to save this patient in a fire, well, what's the difference if I back out and I'm a coward and I don't want to do those skills in the back of the ambulance? That patient could very well die because I don't control that airway in the trauma patient. We know that hypoxia is part of the trauma triad of death, right? Yeah. And those patients, that oxygen decreases the longer they go. They're going to die. Right? So to me, that's the same thing. And what does it matter if you're in the life-saving business? What's the difference between pulling somebody out of a burning building, right, or doing some cool technical rescue, swift water or whatever it is, right? And being capable of managing a complicated medical patient. Right? At the end of the day, you're still potentially saving someone's life by being knowledgeable and capable to do your job.
Correct. And I think in defense of in the past, well, it's tempting to just want to get the patient out of your hands into somebody who can fix them.
Right. And at times there's things, trauma patients, sometimes you need to do that.
You've got to load and go.
Absolutely.
But, you know, for a pediatric, patient, PD cardiac arrest, you got to stay and get patient stabilized, do those things right away.
Yes.
Delaying those things will kill the patient.
Absolutely.
So I think there's a knowledge part of it, and where I think maybe almost like this false sort of a culture of the best thing we can do is to get them to the people who can fix them.
Yeah.
And that's old. That's archaic. That's not true anymore. Same thing I think can be true, and even in the ER, where you want to get that patient out of the ER so you can start moving people. Well, sometimes it's not really good to do that. Sometimes you want to keep a patient in the ER because at night they're going to get lost, and they're at risk for fill in blank.
Right.
So there's a temptation too to offload even in the ER.
Yep.
And to get people out of the ER fast. So I'm just going to prescribe the antibiotics. Just make mom happy.
Yeah.
Well, that's not good.
Right.
Not good to overprescribe antibiotics.
Yeah.
It's probably virus.
Yep.
And antibiotics could even make them worse.
Right.
But mom's happy, and she's out of my ER, so we're good. There's a temptation to do that. So.
Yep. It's like transporting patients to the wrong facilities, like especially with pediatric patients.
Yeah.
You get that pediatric patient pre-hospital, and I've got 2 hospitals that don't deal in pediatrics in my city, so I got to go out of my city to go to a better facility for that pediatric patient. But, this place is 5 minutes away, and that's 15 minutes away, and I want to get back and eat dinner, or, and I get it. It's tempting. Maybe you're tired, whatever the case may be. I get it. But, don't get jaded I guess is my overall point. Like, if you're getting into the fire service, understand that this is going to be the bulk of your role.
Yep.
And as you said, they're starting to collect more and more data, and paramedics are being held more and more accountable to the days of, just give them a dose of diesel and run them to the hospital is not going to really be good anymore.
And I think if people are trying to do the right thing and stay up to date with literature and understand what is best for the patient, it might be best for the patient to not just get up and load and go. There's things I should do right now, or at least en route.
Yeah.
But it's not just in the pre-hospital environment. There's a lot of literature coming out everywhere. Medicine's changing fast.
Yeah.
And with AI, it's changing even faster because we're able to look at data differently than we've ever seen it. So we're going to see a lot of change, I think, in the next few years. Yep. We thought things were changing exponentially fast before, but with the advent of AI, and oh my gosh, things are really changing even faster than we ever imagined they could.
Yeah.
In fact, I don't even think we can keep up with the technology.
Yeah, it's going to move faster than we are.
Right.
Yeah.
Things are changing so fast. It's like month to month we're getting new information.
Right.
So I think there's a responsibility that we have if we really want to do the right thing and save the person from the burning building. Figuratively, that whether you're an ER doc treating a cardiac patient or you're in a nursing home looking to identify sepsis or whatever it might be, you're saving lives. And if you stay up to date and optimize your care, you're decreasing mortality rate. And I think that's saving lives, right? Is if you have an opportunity to decrease the risk in a patient dying, that should be just as praised as saving a baby out of a burning building.
Absolutely.
Well, maybe not as sexy, but by decreasing mortality rate.
Yeah. I'm laughing because that's the difference. Yeah. In my mind, that's the difference. And to me, this is a cultural thing, is that it's more sexy. Right, you're going to be, if I pull a baby out of a burning building, I'm going to be on the news. Oh, hero, firefighter, save. I have had, I don't know how many patients, cardiac arrest patients are really sick. I've never had the news call me and be like, hey, I heard you had this really sick septic patient and you gave the appropriate, that doesn't happen. And so a lot of it, again, this is probably going to piss off some people, but a lot of it is really based on our ego as firefighters, is we want a little bit of that hero complex, and to a degree so. I get it,
we all
right?
Want that,
But like you said, I get just as much self-satisfaction of knowing I had a difficult medical patient, trauma patient, whatever the case may be, that I was able to manage that patient. I activated that statement. I recognized it. I activated that statement, whatever the case may be. And that patient had a better outcome because of what I did. To me, that's just as satisfying as a feeling, right?
Yeah.
So,
and I think that if you can find the satisfaction in that, the fulfillment in that, you're not going to get on the news. You're not going to have the family, honestly, isn't even going to know to thank you.
Correct.
You know who they're going to thank?
The doctors.
The ICU doc that's discharging them. It's like, wow, I was that sick, I didn't know.
Yeah.
Wow, doc, you're amazing. And they come back to the ICU to bring that guy cookies.
Yeah.
Right?
Well, I will say this, though. Yeah. I have had patients come back and bring us stuff to the stations.
Same in the ER. We've had that, too.
Yes. Yeah, as a matter of fact, the first guy, so in the fire service, at least in my department, a true CPR save is not when you just get a pulse back. It's when the patient comes back and shakes your hand. That's what we consider a CPR save, right?
Discharge home. That's the outcome measure.
Well, but we don't always get that. Like, we don't know when and now we do. We get outcomes. But I remember this is way back before any of that happened. I'm talking 18, 19 years ago. We went on a card. It was probably one of my first CPRs we ever went on. Went on this guy, older gentleman. We worked the code. We get ROSC on him. We get him into the ER. And about a week later, we are sitting in the fire station. It was a Friday night, about 9 o'clock. We're sitting in the fire station, and there's a knock on our door. And we go, and here's this guy. Well, I didn't recognize him at first, because totally different context, right? And he extends his hand out. Hey, my name is blank, and he says, my friends call me Lazarus thanks to you. And I'm like, what? And he's like, that's don't awesome. You remember us? And then his wife's kind of emotional, and he tells us, I was the guy that you guys ran on. And I've had that only a handful of times. Right? And they brought whatever ice cream.
It's amazing when that happens.
Oh, it's so. Literally, when you can see that impact, and that's what I want to encourage the future firefighters on, is that that is a very fulfilling, when you have a wife who is crying, or the mom of a child that is crying emotional because they're overwhelmed with emotion because you, whether it was a life-saving thing or you made the right call, whatever the case may be, that is a very satisfying feeling.
Yep. No, it is.
You know, I'm sure you've had that as a doctor. I would hope so. As an ER physician.
Definitely. People come back and thank you for whatever. Tons of cases come to my mind where you unfortunately, the patient comes to me unresponsive.
Yeah, right.
The patient never gets to meet me or see me, and then they end up going to some other doctor who, when they wake up.
Thanks, Adam.
Yeah, right. I mean, it's like, it's okay.
Yeah.
Because we know that what we do matters, and we save lives.
Yeah, we shouldn't be doing this for a bunch of praise.
No.
I mean, we like to be praised. Everybody likes to be praised and thanked.
You need it from time to time, actually. I think we should be doing that to one another.
Exactly.
Really
that should be coming more from the departments because we see it more. We're looking at the cases. But I mean, if you're doing it to be on the 6 o'clock news because you're a hero,
you're going to be discouraged because it's probably not going to happen.
Probably not going to happen. That's right.
I remember the story of our friend Brenda.
Mm-hmm.
This is a good day to talk about this, actually.
Yep.
And
we've said her name with permission, just so everybody's clear.
Yeah. And so her son, because of people recognizing patterns that we were teaching, saved her son's life. That's a neat story, and to talk to her and to hear the story and to share it with other students. That's a little bit of what we can do. It doesn't happen every lecture.
No.
Right? But I believe, though, if we can teach in an evidence-based way where we can learn those little tricks to decrease mortality, we may not hear the thank yous, but they add up. What we learn really matters, and we can save lives little bits at a time.
How appreciative do you think her son is that she was able to identify?
Or his son.
Huh?
His son now has a dad.
Yeah, there you go. Yeah, exactly. Yeah.
I mean, it's really scary.
Yeah, when you think of it, does it matter that it was not in a fire and it wasn't this sexy, dramatic situation? To him, it doesn't.
That's right.
Like, to him, it was the worst day of his life, and, things happen that way. And so...
Diagnosis missed in the urgent care, made in the ER because of a persistent mama.
Yeah.
And a doc who was willing to listen.
That's right. And you can do that as a paramedic, or an EMT, right? Yeah. You notice something because you're paying attention to things and you're listening to podcasts and staying on top of stuff. You could educate doctors on things. And that's a pretty...
What happened
in Idaho,
right?
yeah.
Do you remember that story?
The guy told you the story.
Well, he called, went through our website, wanted to talk. I talked to him on the phone, and he shared with me how he recognized a sign. His partner
listened to you speak.
That's right. Yeah. The stuff we've been teaching in our stuff matters. In the virtual environment, you can learn a lot.
Yep.
And it sharpens skills. Well, he taught the ER doctor a new sign on an EKG.
And the cardiologist.
They took the patient to the cath lab. It required 2 stents, and that saved that 80-year-old woman's life. Somebody's grandmother was rescued.
Yep. Well, and at the end of the day, you did your job. You did your job. You were forward thinking. You were staying on top of things. You did your job, right? That should be enough satisfaction that, hey, the end result isn't up to me, in my opinion, but I did my best. I did my job. That should be satisfaction.
We're all links in this chain,
right?
And if we can all do our job, that's how people say, get the best care. Now, for some people, it's just their time to go.
Exactly. That's what. Yeah, exactly. You can do everything right, and this patient still dies. Right. That's not up to us. I think we all agree with that.
That's right. But if we all do our job, decrease risk to patients, that's what saves lives, and that's why we do what we do.
That's right. And then we're breaking down these difficult concepts.
Yeah.
And that's so you guys don't have to read all the crazy research papers. We'll do that for you. Break it down into little nuggets, and you can ingest those nuggets as you like.
I think you've given us a real clear picture of what it actually looks like.
That's what the real fire service looks like. Yeah. See you on the next one.
Safe out there.
You are listening to EMS with your hosts, Erik Axene and Matt Ball. Thank you for listening to EMS, the Erik and Matt Show.